morning. First I want to express my appreciation for being here for a couple reasons. One, this is a pretty big deal that y'all have here. But secondly, yesterday our institution implemented a new electronic medical record. So I was able to not be there for that, and for that I'm eternally grateful. We're going to spend the next little bit talking about blunt cerebrovascular injury, and as you can see from the title, it's does it need to be diagnosed? The answer is yes. Any questions? This really sort of came to light, at least in the general population. If you think about it, if you remember about 10 years ago, there in this reputable medical journal, Sports Illustrated, which I might add I stopped my subscription to after they wrote a couple of bad articles about the University of Notre Dame. And unfortunately, my canceling my subscription did not bankrupt them, so I was a little disappointed in that. But nonetheless, they wrote this when a young girl was hit in the head with a puck. And this report is actually pretty in-depth for Sports Illustrated and really for just about any journal, but it was a very interesting explanation as to why she died of an occluded vertebral artery. And just a couple of excerpts from this. After she was struck, she retained consciousness and went to the Children's Hospital, where she was treated for a gash on her head. She had a seizure. They watched her overnight and sent her home the next day. After that, she developed a high fever, lost consciousness, was taken back to the hospital, and she died 2 days shy of her 14th birthday. The reason that she developed fever and all that is because she, at that time, had likely herniated. They spoke with an ER physician from Georgetown, who said this is just an incredibly rare thing. I wouldn't have thought of that. Anyone who says they would have is lying. Pretty strong statement, considering the fact that blunt cerebrovascular injuries really aren't rare, and they occur anywhere from 1% to 2% of the population are the victims of blunt trauma. And if you consider the number of patients who suffer from blunt trauma in the United States, that's really quite a number of patients. So really there's several issues. One is screening. Who should be screened for blunt cerebrovascular injuries? And should it be based just on risk factors alone, or are there other things that we can use? Second is how do we adequately and accurately establish the diagnosis of blunt cerebrovascular injury? And finally, what do we do about it? Once we find out, then what do we do? Now, so let's talk about screening first for just a second. Probably the most accurate way to screen is to perform angiography. It's the gold standard. And then it also offers therapeutic options at the time. However, it's pretty resource intensive, and obviously it's quite invasive. Now, as CT technology has improved through the years, CT angiography is hopefully going to become a better way to screen and perhaps even establish a diagnosis of blunt cerebrovascular injury. Everybody and their brother has a CAT scan in their hospital, but it really has unproven reliability at this point. If we look at some of the literature about using CTA as a screening test, initial studies have been pretty enthusiastic about the use of CT, with sensitivities in the 70 to almost 100% range. However, more recent data has demonstrated that maybe not so much, or as Lee Corso would say, not so fast, my friend. If we look at the traditional screening criteria for patients with blunt cerebrovascular injuries, it's basically people who have fairly significant trauma about the head and the neck. Okay, severe facial fractures, Lefort 2 and Lefort 3s. Skull-base fractures is obvious because as the carotid courses up into the skull base. Patients with cervical spine fractures is very easy to visualize a vertebral artery injury. If they have a seatbelt mark, so a direct blow to the carotid. Horner syndrome by injuring the sympathetics as they run along the internal carotid, and then simply an unexplained neurologic deficit. Still, with this traditional screening criteria, we miss about 20% of the injury. So is there a better way to do this? Well, we tried to take this on at UT in Memphis. And as an aside, the trauma center is named the Elvis Presley Memorial Trauma Center. It really is called that. It was named after the king allegedly died back when it was built around 1980. And as a little bit of trivia for you, it remains the only freestanding building named in honor of the king in the entire world. So that little bit of trivia will perhaps, earn you a beer in the bar or something. But nonetheless, that part is true. So we took patients, and as per our institutional protocol, if a patient is involved in blunt trauma and they go to get their CT-orama, if they get a CT of their head, then they automatically get a CTA of their neck. That's our protocol. And if they meet the standard screening criteria, or if they have an abnormal CTA of their neck, then they get 4-vessel angiography. So all these patients in this particular study had both CTA of the neck and digital subtraction angiography. We used a 32-slice CT scanner for this study, and then reviewed the charts for standard sorts of things. Now, if you look at the results, over the study period, there were 28,000 trauma patients who were evaluated. 750 of them were screened with angiography. And of those, 117 patients had injuries, and many of them had multiple injuries, which winds up being about 16% of those who were actually screened. And a fairly even mix between carotid artery injuries and vertebral artery injuries. And then this demonstrates the percentages of patients. You can see it's all 15 and 25% or so. The most important, of course, is an unexplained neurologic deficit, because that's certainly a huge trigger that something's going on in the cranium. But nonetheless, these were the incidents, these were the rates of patients with blunt cerebrovascular injury for this particular study. Now, if you add abnormal CTA as a screening tool, that bumps it up to about 50%. And if you just look at abnormal CTA only without any of these other standard screening criteria, still about 40% of those patients will have a blunt cerebrovascular injury as demonstrated by CTA. So the added value then of the CTA criteria, if we take these 143 injuries, not patients, but injuries, if you look at CTA only, it added another 23 patients or so, most of whom suffered from blunt carotid injuries. So really what that does is, we knew we were missing about 20% with the standard screening criteria. Now we've added an additional 16%. So we've almost been, if we use CTA as a screening tool, then we've almost been able to capture all the patients with blunt cerebrovascular injuries. Not quite. So really the role of CTA, again, we think it should be that you perform a CTA on anybody that you're going to scan their head for anyway. Because if they're abnormal and you're going to perform a CT of the head and they get a CTA in the neck, use the standard screening criteria for 4-vessel angiography in addition to using CTA. But at least in our hands, abnormal CTA is a very good screening criteria, but not yet is it an accurate diagnostic test. Because when you think about it, I mean, the diagnostic test really has to be accurate if we're dealing with blunt cerebrovascular injuries, because if you miss an injury and that patient has a stroke, then that's a devastating problem, obviously. So we have to have very, very high sensitivities in order for this to really work. But again, screening for blunt cerebrovascular injury is a moot point if we don't have effective therapy for prevention of stroke. So even if we can identify the patients, then what do? Do we treat that? Do we not treat it? Do we observe them, treat them with skillful neglect? It's hard to say. So if we look at the incidence of stroke and blunt cerebrovascular injuries, it occurs untreated in about a third of the patients with carotid injuries and about 15% of those with vertebral injuries, with a significant stroke-related mortality of between 5 and 15% or so. In this paper out of Milwaukee, they demonstrated that the lifetime cost of stroke is over $600,000, and if we could get the CTA sensitivity to 93% or so, then angiography becomes, if the CT sensitivity remains below 90% or so, really 93% is what they showed, then angiography remains the most cost-effective test. Well, if we look at CTA as a screening test, we can see that aside from this one manuscript from Dallas in a relatively small number of patients where they had very high sensitivity, no one else has been able to reproduce that data. So I think CTA is probably good as a screening test, but certainly not good as a diagnostic test. Now, why do patients have problems if they have a blunt cerebrovascular injury? Well, it all comes down to whether or not they have an intact circle of Willis. And as you know, the circle of Willis is the circle of vessels in the skull base that connects the carotid system with the vertebral system. It's a key issue concerning stroke in these particular patients, and it's most important for the potential for collateral flow. The sad thing is that even though rats have about 100% or so intact circle of Willis, humans only have a completely intact circle of Willis in about 20% of cases. And that's fairly important relative to the development of development of symptoms following blunt cerebrovascular injury. And most of these variants are due to segmental hypoplasia. You can have posterior communicating arteries in about a quarter of the patients that are hypoplastic, missing either part or have a hypoplastic anterior cerebral in a quarter of the patients. Another 15% or so have posterior cerebral artery hypoplasia. So these are the most common anatomic variants, but again, it doesn't really take very much to realize that if you don't have an intact circle and you have an injury or an occlusion to one of the four vessels going to your head, then it's pretty easy to see that this person may very well be symptomatic on that side. The other thing is that typically if someone's going to develop a stroke or symptoms, they don't always occur shortly after the injury. About half the patients occur in greater than 12 hours or so, and about half the strokes greater than even 24 hours, and sometimes even it can be several days, as in the poor, unfortunate young lady in the Sports Illustrated article. Now, why not just take all these patients to the operating room and fix them? I mean, that's what we would do if somebody was shot in the neck or if they were stabbed in the neck. We would just take them to the operating room and fix them. Well, the problem is that typically these injuries are in the internal carotid and they extend all the way up to the skull base. So you have a blunt injury, which is completely different from a penetrating injury. So on this blunt injury, you've got a ratty vessel or an injured vessel for an extended period of time, and even if you could expose the carotid at the skull base, typically the dissections will extend up into the skull base, and technically you just can't get there. You just can't fix it. So performing an interposition graft is not really a good option. So what then are our options? Anticoagulation therapy. Anticoagulation therapy will prevent thrombosis in patients who have a dissection. It can decrease embolization, and it will prevent propagation of clot so that hopefully we don't take a bad problem and turn it into a worse problem. Now, anticoagulation for the treatment of cerebrovascular injury is not really new. Even the neurologists figured this out back in the 50s and used anticoagulation in patients who have stroke, but timing is really the issue. Now, the rationale for antithrombotic treatment is that most of the cerebral ischemia that we see following blunt cerebrovascular injury is embolic. Sometimes cerebrovascular injuries can be complicated by patients with associated brain injury. In fact, that's not an uncommon problem at all. That's why we need adequate screening techniques and four-vessel angiography to establish the diagnosis. Now, contraindications, I must admit, it sort of makes you a little bit nervous to take a patient who has bilateral femur fractures, pulmonary contusion, a sliver subdural in their head with a cerebral contusion, who also has a big dissection of their left internal carotid artery. That makes you a little bit nervous to start that patient on heparin. Obviously, there are obvious contraindications. For example, the patient, when you have blood on your shoes when you're taking care of them, probably not a good patient to start on heparin. If you're getting ready to operate on them for exsanguinating hemorrhage, again, probably not the right patient selection. On the other hand, even though it makes you nervous, still it's just a relative contraindication in patients who have intracerebral hematomas and subdurals and whatnot. So that's why we try to keep the PTT in the 40 to 45 range. Okay? We don't completely systemically anticoagulate these patients. We keep it in the 40 to 45 range. In fact, wrote a paper about this back in the mid-90s that Dr. Fabian was the first author on. And if you independently look at, in logistic regression, if you look at the independent predictors of outcome, we found that severe brain injury, as one would expect, impacts survival. That's not rocket science. But heparin, institution of heparin in these patients with blunt carotid injuries was independently associated with both neurologic improvement and survival of their injury. And in fact, one sort of interesting subset of patients are people who have bilateral carotid injuries, right? So one side can serve as the own control. And in patients who were symptomatic from one side, they were still started on heparin, and the asymptomatic side remained asymptomatic. Now, again, this isn't as good as a prospective randomized trial, and there's only about 15 patients in this particular study. Subsequently, we've upped the numbers, and this continues to hold true. But again, it's not a randomized trial. That's never going to happen. Okay. The group from Denver has also published quite a bit on blunt cerebrovascular injuries and stated that anticoagulation is the gold standard therapy. And in fact, if you look at their data, those treated with anticoagulation have a very low stroke rate compared to those with no initial treatment have a very high stroke rate. Even the group from Baltimore demonstrated that treatment does in fact matter. They had 22 strokes for an overall stroke rate of about 11%. Half of those patients died. A quarter of the patients had a stroke if they were untreated, and only 4% in those that were treated with anticoagulation, and thus they concluded that treatment does in fact reduce the risk of cerebral infarction in patients with blunt cerebrovascular injury. Now, what sort of anticoagulation or what sort of treatment do we need? Do we start everyone on heparin? Do we just give them antiplatelet therapy? The answer to that is sort of how long is a piece of string, and you have to individualize that treatment to the particular patient. One of the problems with the antiplatelet agents, of course, is that they're irreversible. It also helps if you actually look at what the pathology is. And in our series, a third of these patients went on to develop pseudoaneurysms. And the group from Denver, likewise, had about a third of the patients with angiographic pseudoaneurysms. And the pseudoaneurysms don't get better over time. They just tend to get worse, as you can see. Patients with a dissection will get better over time, but a pseudoaneurysm won't. So what do we do for those patients? Intravascular stenting with coiling of the pseudoaneurysm is probably the best treatment of that. We tried to address that actually by tailoring the treatment to the lesion, and our protocol for early low-grade injuries, excluding those that are occluded and have AV fistulas. We initially start heparin on those patients, repeat their arteriogram. If it's not healed, then they get endovascular treatment. If the vessel's occluded, then they get aspirin alone. If it's a fistula or a transection, then hopefully we can treat those with endovascular. We had 220 patients with cerebrovascular injuries, 263 vessels injuries. Again, a similar ratio between carotids and vertebral injuries. 29 patients in this particular series had bilateral injuries, and a number had both carotid and vertebral injuries. Of these, 22 patients had an infarct before their diagnosis, so that left 200 that were asymptomatic at the time of diagnosis. Okay, there's not much we can do about these 22 patients except hopefully get them to the hospital a little bit sooner after their injuries. Most of these were vertebral, but of the 74, there were 2 patients who suffered a stroke prior to treatment. 22 were treated with anticoagulation, and 50 of these 74 wound up getting intravascular stents to treat primarily refractory pseudoaneurysms. One thing I've noticed is it doesn't matter how hard you push this. If you keep, it really doesn't make it go any faster. Of the 130 patients with vertebral artery, there was 1 patient who suffered an infarct before. The overwhelming majority of the patients with vertebral artery injuries were managed with anticoagulation and or aspirin. We then got follow-up on these patients. About 85% of those we had follow-up on, and there were 6 additional patients who suffered a stroke for a 7% post-diagnosis stroke rate. 5 people potentially had a stroke. It was difficult to tell because those 5 patients also had associated brain injuries. So it was difficult to tell. So we erred on the side of calling that a stroke, and there were 13 patients who died. So if we look at this previous algorithm and look at the medical and the endovascular treatment, we see very acceptable stroke rates for both medical and endovascular treatment. Again, if the patients are chosen properly, then we can have very good rates. And if you look at everyone together and look at the current literature, we see that our stroke rate of 4% after diagnosis really compares quite favorably with the literature following this particular algorithm, an overall mortality of 11%. So currently, this is the algorithm. This is what I'd like to leave you with. If a patient comes in following blunt injury and they need a head CT and they get a cerebrovascular CTA, okay, then there will be one of three things. Either they have a negative CTA without screening criteria, and in that case, you're done. Okay? If they have the standard screening criteria or have a positive or intermediate for blunt cerebrovascular injury, then those patients need to go on to get 4-vessel angiography. And with the angiogram, it's either going to be normal, in which case you're done, or you confirm the fact that they have a cerebrovascular injury, and then depending on where it is, whether the vessel's occluded or not, they either get aspirin or heparin. If they're on heparin, they still get a repeat arteriogram, because the people that get aspirin are those that have occluded vessels, so that's not going to get better. So the people that are on heparin then get repeat angiography, and then if the lesion is healing, we continue anticoagulation. If the lesion is not healing, then those patients undergo endovascular treatment. So the key with endovascular treatment is to keep them on their aspirin and I don't like using trade names, but I can't really pronounce, so I say Plavix. It's a whole lot easier to pronounce. Maybe people outside of Tennessee can pronounce that a little bit better. I don't know. But I'll just leave you with these thoughts. The diagnosis of blunt carotid injury does require a high index of suspicion, but it's not rare. Vertebral artery injuries are not as rare as we thought either, and they really should be aggressively treated because a posterior circulation stroke is devastating and not uncommonly fatal. The standard screening criteria have really been validated, but CTA lacks sensitivity to be a screening criteria alone. If we add CTA to the current screening criteria, we can identify about 95% of the injuries, which is pretty good. And finally, antithrombotic therapy with selective stent placement is probably the mainstay of therapy. And I'll leave you with this picture of the trauma center. Once again, I'd like to thank the organization for the privilege of being here. Thank you.